Good evening, ladies and gentlemen. I'm Dr. Li from Shenzhen Maternity and Child Healthcare Hospital, South Medical University, Shenzhen, Guangdong, People's Republic of China. It is really an honor for me to give a report here. My topic is a novel platter ultrasound scanning approach, one-touch technique in second and third trimester. I have no conflicts of interest to declare in regards to this topic. When we mention artificial intelligence, we can immediately think of robot, driverless cars, AlphaGo, etc. And AI also have a huge contribution in medicine. For example, pathological diagnosis system, CD intelligent diagnosis report system, high throughput sequencing technology, Da Vinci surgical robot, and artificial intelligence in ultrasound now came into people's view and has already made certain achievements. Traditional obstetric ultrasound is still a manual process highly dependent on the user's hand. For example, during the acquisition of AC, we will take procedures about 10 to 15 procedures. First, you scan the fetus, then freeze the frames, replay and judge the sections from the thin lobe, select the parameters A, C, move the first cursor, confirm, move the second cursor, confirm, adjust the measurement clippers 2 to 5 times. At last, finished. This will take about 10 to 25 seconds. Could this tedious operation be simplified? Is there a way to simplify the procedures and improve the quality of obstetric ultrasound? We think one solution is embedding expert knowledge into ultrasound equipment. A new platter ultrasound scanning approach, one-touch technique, we call it S-fetus, was developed. S-fetus means smart fetus. When you scan fetus, the S-fetus can automatically complete the acquisition of standard views and the measurement of fetal parameters. You only scan the fetus. The other workers will be done by touch the fetus. S-fetus has two core functions: smart fetus acquisition and smart fetus measurement. Smart fetus acquisition was designed to automatically distinguishes, acquires these 3 standard views, and measures 4 basic fetal growth parameters during the real-time scanning. And smart measurement do not select views, it only measures the parameters. The main purpose of this study was to evaluate the efficacy of SF, to test the agreement of TUT and SF, and to compare the required time by TUT and SF. Methods: 1,005 low-risk pregnancies between 16 to 41 weeks gestation was entered into the study. All the fetuses were normal, no anomalies. 2 certified sonographers carried out the scanning. Both traditional ultrasound method and SF were administered in target population. The time and all the images were recorded for analysis. Here are the statistics we have calculated in the study. P less than 0.05 was thought to be statistical significance. Results. Table 2 and Table 3 shows the intra and inter-observer variability for fetal biometric measurements. Even though the inter-class correlation coefficients of traditional ultrasound method were both higher in intra and inter-observer agreement, but the SF performs even better. All ICCs of SF were 1, which means in the same image, no matter who took the measurements with SF and how much time he measured, the results would be shown the same, greatly reduce the intra and inter-observer variability. In the assessment of SF for the 3 sections requirements, clinical acceptance in one acquisition is very, very high, and 95% for section A and 96.7% for section B and 99% for section C. And the total clinical acceptable case is also very high. In the quality assessment of automatic measurement, more than 98 cases were considered qualified in one measurement. No failure in the measurement of the head was noted. In cases measured more than once, including failure cases, over-measured and under-measured cases were close to 50% and only for AC and FL. Table 7 shows you degree of reliability between TUT and SFA measurements. A high degree of reliability was observed between TUT and SFA in 4 parameters measurements. Figure 1 displayed the blind abdomen plots for mean difference, clinical acceptance, and 95% limits of agreement between TUT and SFA measurements. The result is very good. The histogram shows the time needed for both methods. The blue column is for TUT and the green column is for SF. The time required by SFA for the acquisition of 3 standard views and the measurement of 4 parameters was much shorter than that by traditional ultrasound technique. The time is 7. Discussion. Our group have been working on the artificial intelligence of obstetric ultrasound since 2006. After 15 years exploration, we have the revolutionary development of obstetric ultrasound AR. Currently, Sonoscape manufactures the A60, which has launched a one-touch automatic AR project that subverted the normal flow of operations. We call the S-fetus acquisition and S-fetus measurement. Here are some data in our previous research. The AR model measures accurately. With this AR technique, all we need to do is to scan the features and then touch the AR key. All three essential standard sections and 4 filter parameters will be automatically obtained. This is the application of 2 methods by one physician in the same filters. The up pictures are obtained by TOT, and the bottom are obtained by S filters. The 2-line filters look like the same, and the measurement are showing no obvious difference. It's the same, you see. This is the real-time record for 2 methods to obtain the transverse section of the thalamus and the measurement of BBD and the HC. With the traditional ultrasound method, we will take 40 seconds to complete in 23 steps. But with the SF, with the smarter filters, we will only take 3 seconds to complete in only 1 step. Much easier and quicker by SF than by TOT. Let's have an imagination. With the use of SF, the time saved approximately 31 workdays, and the steps will save 468,000 steps per year. The significance of S filters, we think, is to initiate the new concept of standardized filter intelligent ultrasound, include embedded ultrasound AR into physicians' workflow, improve the workflow efficiency, reduce procedures, improve accuracy and reproducibility, save time for filter structure observation, reduce training time, lay the foundation of further obstetrical ultrasound AR. You scan only, and the other work will be done by S filters. Future development of AR obstetrical ultrasound, we think the one-touch technique will be replaced by fully automation. Scanning by robots and fulfill the fully automatic obstetrical ultrasound. Looking forward to the future working mode is worth expecting. Thank you.
It's my great pleasure to speak in the 15th World Congress of Prenatal Medicine. My topic is the application of fetal heart navigation in diagnosis.
Professor, sorry, by the way, do you have presentation? So PowerPoint or PPT?
Pardon? I don't share. I don't. Oh, just a moment.
You haven't shared yet.
Yeah, I will show. Now it's okay.
Okay, now we see.
Sorry. I will begin again. Yes, sorry.
Can you do it full screen? Okay, now. Okay, thank you.
Now it's okay.
Thank you so much.
So my topic is the application of fetal heart navigation in diagnosis of common contract defects. I'm Dr. Zhao from the Seransha Hospital, Zhejiang University, Hangzhou, China. So in the past 70 years, much more attention has been paid to women's health and birth defect control in China. So both natal mortality and maternal mortality has considerably decreased. So we have saw some improvement both in child and in women. But still, we need a lot of jobs to be done. Prenatal diagnosis of critical congenital heart disease can do some benefits to the newborn, such as improve preoperative newborn survival, improve neonatal preoperative outcomes, and also can decrease the risk of death from neonatal cardiac surgery. So you say from this literature, we say cases diagnosed prenatally maybe nearly 300. The death is the percentage 0.7, but for postnatal cases, it's increased nearly 31%. So prenatal diagnosis is very important for critical congenital heart disease, such as intact interceptor transportation of TGA and total animals drainage of the pulmonary veins. So all the diagnosis prenatally may improve the outcome of the newborns. But we have some challenges because the detection of the fetal congenital heart disease in experienced hand and in obstetric ultrasound examination is different considerably. Also, some congenital heart disease occurred in low risk pregnancy. So, ISUG and American Society of Echocardiography and the American Institute of Ultrasound in Medicine or proposed to screen the fetal heart with a four-chamber view, left ventricle outtract view, right ventricle outtract view, and the three vessel tracker views. So increased views can improve the diagnosis of the congenital heart disease in fetal lives. So now we use 2D, two-dimensional echocardiography and color Doppler flow for its chief diagnosis tool. But still, we want to improve the detection rate of fetal congenital heart disease. The more important thing is operator's ultrasound experience has some significant influence on fetal congenital heart disease detection rates. So some new modalities such as Professor Lee just presented the smart fetal, the real-time three-dimensional echocardiograph, stick, fetal heart navigation, 5D heart, and AI may do some help for us. So traditionally, we use two-dimensional ultrasound. We use manual navigation. So it's a highly operated technique, requires extensive training and expertise to assess fetal cardiovascular anatomy. And most of the time for examining babies to acquire images. After we get the image, we cannot do any post-process because if you get the image, maybe you can get the diagnosis. So it's a time-consuming work. So this is a continuous wave technology proposed by Professor Yager. So this is a very good view. So we can scan the heart from abdomen to the chest. Then we can get the abdominal view with the stomach. We can get a four-chamber view. We can get for the LVOT, RVOT view, and the three vessel changer views together. But this technique must be trained for some less experienced doctors. So a new method was proposed. That's a fetal intelligent navigation echocardiography called FAN. It can automatically analyze the three-dimensional stick volumes of the fetal heart, reassure or display the standard image of anatomic positions in anatomic positions. So we can get the standardized fetal echocardiogram views automatically. So first we get the 2-dimensional one. We can get a 4-chamber view very easily. Then we use volume per transducers. Then we can get the 3-dimensional volume of the fetal. Then by use fan, we can get the 9 views of the fetal heart, such as 3 vessel views, 4-chamber view, 5-chamber view, left ventricle outer tract view, and the right ventricle outer tract view. Stomach in the abdominal views, and the ductal arch view, aortic arch view, and vena cava into the right atrium views. So if we get the 9 standard views, maybe we can make a diagnosis of the most major congenital heart disease. Let's see. So just we use the 7 steps as a protocol, so we can get to the 9 images here. So it's very quickly and standardize the display and show the standard view plans. So when we get the volume, we can do the things step by step to mark the anatomic of the cardiovascular systems by 7 steps. So we can get the 9 view very quickly. So let's say some practice in the congenital heart disease. The first one is tetralogy of Fowler. So the main malformation is with the aorta overriding the ventricular septal defect and with pulmonary stenosis, also with or without right ventricular hypertrophy. So this is a large VSD, a dilated aorta, a small pulmonary. So we stay very clear, large aorta, the small pulmonary, the bigger VSD. By use of this, we can see this view is abnormal. This view may be normal, but here we can see VSD. Here, aorta overriding VSD, the small pulmonary stenosis. So by view all the 9 view together in a same loop, we can make a diagnosis very accurately and very quickly. So you see this view abnormal, the dilated aorta. Here, aorta is larger than pulmonary. The 4-chamber view may be okay. The air view, T view, it's abnormal. Right ventricle view, abnormal. Ductal view, pulmonary stenosis. Second, the congenital heart disease is very common. It's a complex transportation of the great artery. So the main abnormality is the discordance of the ventricle and the artery connection. The right ventricle give rise to the aorta. The left ventricle give rise to the pulmonary. So the 2 vessels is parallel. So you see here is the aorta, here is the pulmonary. So in this view, the 9 views, we can see the 3 vessel church views is abnormal. We just see 1 great artery. Generally, it's aorta. The 4-chamber view, maybe it's okay. In this view, we can see the 2 great arteries arise from different ventricles is in parallel, not cross, so it's abnormal. So just by these 2 ways, we can make a diagnosis very accurate. So here we can see the 3 vessel church view is abnormal. The 4-chamber view, maybe it's okay. If we can't find the big VSD, maybe it's okay. But in left ventricle and right ventricle outer tract views, it's abnormal because pulmonary from the left ventricle, aorta from the right ventricle. The last common contract abnormality is DORV, double outlets of the right ventricle. So we can say both great artery arise from left morphology right ventricle. They're always with the big VSD and maybe pulmonary stenosis. So we say here is a big VSD, the pulmonary here, the aorta is here. So both great artery arise from right ventricle. So by use of fan, we can see, now we can see the first chamber view, maybe it's okay. Here we can see the pulmonary arises from a right ventricle. Aorta is also from a right ventricle here. You can see the stenosis pulmonary here. So three vessel views, we can see the pulmonary smaller than aorta. Left ventricle view and right ventricle, the abstract view is abnormal. It's abnormal. Also, we can use in maybe pulmonary aortic stenosis, coarctation of the aorta. We can see very narrowed aortic arch. So I will give my conclusions. Fetal navigation echocardiography makes the complex things simple because it can show the standard fetal echocardiogram view very simple, rapidly, automatically. So we can successfully visualize of the key fetal echocardiogram views, simplize the fetal cardiac examination. If we get a four-chamber view, we can, by use of fan, we can get the 9 standard views. We can shorten the examination time. We can display and reiteration of the standard views. Again, we can reduce the operation dependence. It's very useful for clinical application diagnosis of common counter-tracking defects. Thank you very much for your attention. I'm glad to take some questions. Thank you again.
Okay, thank Professor Jost.
Hello, I'm Seng Zhao. I come from Hubei Maternal and Child Health Hospital in the middle of China. My topic is ultrasound diagnosis of fetal coronary artery fistula. First, we'll talk about embryology. We know connection of the mainstem coronary arteries and the myocardial vascular channels marks the initiation of a functional coronary circulation. There are some regulations of myocardial perfusion. You know, coronary blood flow is closely regulated to match myocardial oxygen demands. And how to examine fetal coronary arteries? Only in the third trimester can we see the normal fetal coronary arteries in the short axis view of aorta. And we use color and the pulse wave Doppler to determine coronary artery blood flow. The coronary artery flow have both systolic and diastolic peaks and antegrade flow throughout the cardiac circle. And there's some report about the normal range of the peak velocity. Here's an example of a normal fetal coronary artery. We use short axis of the root of aorta. When we use color Doppler, we see a very clear coronary artery here, as the arrow shows. They are both diastolic and systolic flow. In PW mode, we see a predominantly diastolic flow, but also with systolic flow. Congenital coronary fistula may occur rarely if cardiac anatomy is otherwise normal. The incidence is 1 of 15,000. The left, right, or both coronary arteries may be involved, and the fistula will drain into right side of the heart mainly. Here's some example of the coronary artery fistula, sometimes to right side of the heart and sometimes to left side of the heart. There are some complications of coronary artery fistula, such as congestive heart failure pulmonary hypertension, and etc. Sometimes it will close spontaneous, but we can use do surgery or transcatheter occlusion of the coronary artery fistula. This is an report of prenatal and postnatal of fetal coronary fistula. And this is a very huge coronary fistula closed by patches after birth. With fetal echocardiography, we can diagnose coronary fistula. There's no obstruction in LVOT view or RVOT view, and we can demonstrate coronary blood flow in 4-chamber view, 5-chamber view, or the short axis of aorta. With pulmonary pulse wave Doppler, we can find the whole cardiac circle. That means both systolic and diastolic flow. Sometimes the right side of the heart will dilated, and there will be coronary steal effect in aortic arch or MCA. Here's some case of coronary artery fistula. First, coronary artery fistula to right atrium. We see a dilated right side of the heart in the 4-chamber view and tricuspid regurgitation. This is normal, but a little bit narrowed aortic ascending aorta. In the short axis of aorta, we see very clear a dilated coronary artery. And with color Doppler, it's more clear. This is a 4-chamber view. We see the fistula as the arrow shows. This is the fistula in the 4-chamber view. And this is a pulse wave of the fistula with very high peak velocity, above 200 centimeters per second. In the 3-vessel tracheal view, we see coarctation and retrograde flow in aortic arch. And this is pulmonary pulse wave showed. However, there's no signs of heart failure after birth for this baby. After birth, we do echo for this baby. There's a little bit dilated right side heart. And we see the coronary artery fistula very clear. And here. And this is the pulse wave Doppler. Here we see the dilated coronary artery in the right side. And we see the fistula as the arrowhead showed. And there's some level of coarctation in the aortic arch. This is the CTA shows very clear. Normal RCA and dilated LCA. Dilated LCA. LCA. And coarctation. Okay, this is another example. We also we see a dilated right side heart also. And when we pay attention to the root of aortic ascending aorta, we see very clear a dilated LCA here. And this is Doppler. We see the dilated LCA enter into the right atrium here as the color shows. And this is Doppler, both systolic and diastolic flow. When we see the short axis of aorta, we see very clear a dilated coronary artery as the color Doppler shows, as the arrow shows here. This full-chamber view, we can see the dilated LCA comes into the right atrium, and this post-wave. Okay, this image is quite clear to show the fistula and the 4D view. You see both systolic and diastolic flow. And when we see the aortic arch, there's no coronary steal effect. There's no sign of heart failure after birth. And our diagnosis is confirmed by CTA, as this arrow shows the dilated coronary artery. The baby have surgery in 8 months and he's very good now. Okay, let's move to another case of coronary artery to right ventricular fistula. We see a little bit dilated RV, and we can see the color. There's a dilated vessel here. The LVOT view is normal. The color is normal. And for the pulmonary artery, it's normal. However, there's also crossed the pulmonary arteries. As this 2D and the color Doppler shows. And when we see the short axis of aorta, we see a very clear and dilated vessels. That's coronary arteries. It measures 0.27 centimeter. And this is color Doppler, the post wave. And we see the RCA is dilated, color Doppler, and the post wave. Okay, the 4D color Doppler showed very clear the coronary artery to right ventricular fistula here. In the 3-vessel tracheal view, we see normal size aorta and the pulmonary artery, but retrograde flow in aortic arch. That means coronary steal effect, as is shown in the post wave. And this is aortic arch view. We also see the coronary steal effect. This is the MCA. When we follow up in 29 gestation weeks, we see nearly the same sign. This is the fistula. You see the dilated coronary artery, color Doppler, and the post wave. And we see very clear the fistula, like this. Followed up in 34 gestation weeks. The same as we see before. The fistula is very clear here. And there's also coronary steal effect, as shown in this aortic arch view. And also in MCA. And this cross pulmonary artery, very clear. Okay, this baby also have also confirmed the diagnosis after birth. We see very clear the coronary artery, the fistula. The dilated RCA and the coronary artery. Okay, in summary, fetal coronary artery may be visible only in the 3rd trimester. Coronary artery fistula can be diagnosed in fetus, and following coil embolization or surgery of the coronary fistula, the further clinical course was uneventful. Thank you so much.
We would like to thank Dr. Zhou's excellent
Good morning, good afternoon, and good evening to everyone. I'm Qiu Yanpei from Peking University People's Hospital, China. My topic is prenatal diagnosis and differential diagnosis of small left heart. And I will illustrate with special cases of small left heart. Small left heart includes left heart volume reduction and hypoplastic left heart. Among left heart volume reduction, they are lengthy foramen ovale valve, persistent left superior vena cava, coarctation of aorta, total anomalous pulmonary venous connection, and others. Traditionally, we think in the left heart volume reduction, the left heart is slightly smaller than the right. The right ventricle forms the apex with automature and aortic valve dysplasia. The risk factors resulting in left heart volume reduction. And in hypoplastic left heart, the left heart is significantly reduced. The right ventricle forms the apex, the rhythmature and aortic valve dysplasia. So it's easy to make differential diagnosis. For example, in case 1, the pregnant woman was 31 years old. The fetal gestational age was 25 weeks. Fetal heart scan showed the left heart was slightly smaller than the right. The left ventricle forms the apex. So the pregnant woman was referred to us for further investigation. This is a four-chamber section. We can see the left heart is slightly smaller than the right one, and the left heart forms the apex. Mitral and the aortic valve are normal, and a lengthy foramen ovale valve exists. So the diagnosis is lengthy foramen ovale valve, left heart volume reduction. The baby was full-time uncomplicated labor with birth weight 3 kilograms. On the first day of life, echocardiogram showed the size of the left heart was normal. In fact, left heart volume reduction is very common, and a large amount of data has been accumulated in supporting the differential diagnosis. But sometimes, in left heart volume reduction, the left heart is not slightly smaller than the right, but significantly smaller. The right ventricle forms the apex, not left ventricle. Factors resulting in left heart volume reduction is not obvious. And in hypoplastic left heart, the left heart is not significantly reduced, but slightly reduced. Mitral and aortic valve dysplasia is not obvious. So in this case, it is difficult to make differential diagnosis. For example, in case 2, The pregnant woman was 27 years old. The gestational age was 24 weeks. Fetal heart scan showed the left heart was much smaller than the right, and the right ventricle forms the apex. So the pregnant woman was referred to us for further diagnosis. This is the four-chamber section. We can see the left heart is much smaller than the right. The right ventricle forms the apex. Mitral and aortic valve are normal, and a septal echo exists in the left atrium. So we have to ask ourselves two questions. First, is it hypoplastic left heart? Because the left heart is significantly smaller than we expected. The right ventricle forms the apex, although the mitral and aortic valve are normal, but maybe there are small mitral or aortic valve lesions that are not yet visible. So hypoplastic left heart cannot be excluded. Second, is it left heart volume reduction? If the mitral and aortic valves are normal, the baby may have left heart volume reduction. But what's the reason for left heart volume reduction? Is it the septal echo? If so, what does the septal echo represent? So, how to manage it? Evidently, we had difficulties in differentiating between hypoplastic left heart and left heart volume reduction in case 2. So we recommended the pregnant woman should return in 2 weeks, and we would repeat the echocardiogram. But she refused and chose to terminate the pregnancy. So we received the specimen and created a database of anatomical cross-section of the fetal heart. And here, there are a few typical anatomical cross-sections at different heart level, left atrium, left ventricle, and here is coronary sinus. We can see it is intact. But here it is not intact. So the baby was diagnosed as unroofed coronary sinus malformation, and here is a residual wall of unroofed coronary sinus. Residual wall of unroofed coronary sinus. And here is a septal echo we found prenatally. And we can see they correspond to each other. That means the septal echo is the residual wall of unroofed coronary sinus. And it's also the reason of left heart volume reduction. As we all know, the outcome of unroofed coronary sinus is good. So it's a pity for the baby to be terminated. Case 3, the pregnant woman was 25 years old. She attended antenatal care regularly in a second-class hospital, and the baby was diagnosed as left heart volume reduction prenatally. On follow-up, the baby was full-term uncomplicated labor, but died of hypoplastic left heart in the neonatal period. So we review the sonogram. We can see the left heart is much smaller than the right one, and the right ventricle forms the apex. But also we can see the length foramen ovale valve. So the baby was diagnosed as left heart volume reduction prenatally. But the mitral valve prolapse, here is the mitral valve prolapse, was missed. So the baby should have been diagnosed as hypoplastic left heart. From above cases, I would give following message. First, most of the time, it is easy to make a differential diagnosis between left heart volume reduction and hypoplastic left heart. But sometimes it is difficult to make a differential diagnosis between left heart volume reduction and hypoplastic left heart. And the following, I would like to state. So far, there are still many problems related to the left heart that we cannot explain accurately. For example, the fetus was 24 weeks. The size of the left heart is normal, but there is a low to medium mitral valve regurgitation exists. And 2 weeks later, the regurgitation disappeared. So we ask the question, is this a normal process, or are there problems with the mitral valve? At present, we cannot explain the phenomenon. The pregnant women are currently pregnant, so we will continue to follow up and hope to have the opportunity to share the outcome with you in the near future. Conclusion, usually in left heart volume reduction, the left heart is slightly smaller than the right, but sometimes there can be a serious decrease. In hypoplastic left heart, the left heart is significantly smaller than the right, but sometimes the ultrasound features are not obvious. So be cautious in making prenatal diagnosis and differential diagnosis between left heart volume reduction and hypoplastic left heart. And so far, there are still many problems related to the left heart we cannot explain accurately. So it's necessary to accumulate more data to prove prenatal diagnosis. Thank you for your attention.
Situation is difficult. Now it's time for the panel discussion. We would like to invite all of the speakers to come to the discussion session. Is there any questions from the audience? For the audience, you can type your questions into the chat box, and we will ask the speakers to answer the questions, or we discuss the questions together. So all of the questions are welcome. Okay. Dr. Mona has a question to Professor Lee. First, since Dr. Lee has introduced the smart SF AI ultrasound, so what's the future mode of obstetrics ultrasound? This is the first question. The second question is whether AI can make the diagnosis of fetal abnormalities. I think it's very challenging for Dr. Lee. So we would like to invite Professor Lee to answer this question first.
Thank you. I think the first question, the robot scan the fetus in the future and measure the size of the fetus and diagnose some fetal serious disease, all of which are fully automatic. The doctor makes the final diagnosis only in front of a backstage computer, I think. And the second question, I think AI can detect the fetal abnormalities, but the final diagnosis should be made by doctor, I think. Thank you.
So, in your opinion, AI is just a tool for screening first, and the final diagnosis should be made by the fetal echocardiography by experts in fetal heart.
Yes.
Am I right? Yes.
Yes.
Thank you. Any questions? Okay. This is the question to Professor Bowen Zhao from Zhejiang, China. The question is, how about the successful rate of fetal heart navigation to obtain the key echocardiographic views? I mean, maybe the question is about how about the successful rate to obtain the standard view which recommended by AIUM or ISUG in the screening for fetal cardiac abnormalities. So Professor Zhao, please.
Okay, thank you very much. Thank you very much, Professor Chen. And thank you for the doctors raise the question. I'm very glad to take the question. So we know fetal intelligent navigation echocardiography is a new method to get the 9 standard plans from the 4-chamber view. So can I share some research? We just let me see. Can you see the slide here? So we just do some research. Let's say, okay, let's see. We just publish some articles for assess the display key diagnostic elements in feature category. It was published in BMC Medical Image. So by getting these views, we can see we totally have 231 photos. So we see that this is 3 VT views. It's nearly 72. The first chamber view 73, LVOT 83. So if this is all the fetal heart in all the direction of the fetal that pick, but for the fetals with epic 4-chamber view, we use the 5. We can see the detector, the demonstrated rate, the success rate is much more improved because the fetal heart is anterior. For posterior, maybe it's a little low. So now you see the abdominal view nearly 100, the left ventricular view nearly 72. So for fetals with different positions, the heart pick maybe to the different position, maybe we have different results. So in the future, maybe if we can improve maybe the image qualities, maybe the success rate will be improved. So I believe this technology it's still developing method. So something must be done for in the future to improve the ability for demonstrated the society recommended standard views. But I believe so far in my experience, it really do some help for the less experienced hands. Thank you very much.
Thank you, Professor.
Professor Chen.
Thank you.
Thank you.
Dr. Xue has a question. Dr. Xue, could you please directly convert this question to the speakers?
Yes. My question is to Professor Zhao Sheng. My question is, which diseases should fetal coronary artery fistula be differentiated from? Thank you
for the question, and thank you for Dr. Xue. When we diagnose fetal coronary artery fistula, we should think about other disease such as ASD, VSD, or pericardial effusion. However, when we use PW, we can find a very typical sign for the fistula, both systolic and diastolic antegrade flow. And for the other disease, we could not see this typical sign. So with PW, we can differentiate from other disease. Thank you.
Thank you.
I want to ask Professor Zhao, when you confirm it's a fetal coronary artery fistula, how to counsel the couples, because they will feel anxious. It's congenital heart disease. How to manage the patient? Shall we terminate the patient, or how about the further management? So, Professor Zhao, according to your opinion, how about the prognosis of this disease?
Thank you, Dr. Chen, my best friend. As I think, fetal coronary artery fistula is have very good prognosis. If there's no heart failure or other structure abnormalities, inactive abnormalities or chromosome abnormalities, we can just follow up the patient to see if there's some sign of heart failure, such as the changes of MCA, the ductal venosis, or the size of the heart. And when the baby is born, we can do surgery or transcatheter to close the fistula and have a very good outcome.
So generally speaking, this kind of coronary artery fistula, the prognosis is good, and is a benign disease. Yes.
Yes, I think. Thank you.
Okay, thank you. Dr. Xie, also from Peking University People's Hospital, has another question to Professor Pei.
Yes.
Please.
Yes, I have a question to Professor Pei Qiuyan. According to our experience, mitral regurgitation often means mitral valve disease or left ventricular dysplasia. You suggest that it may be a normal development process. What is the basis? Why you think about this?
Thank you, Dr. Xie. I think you are right. Traditionally, we think the regurgitation are greatly related to the severe disease, such as mitral valve dysplasia or left heart dysplasia, or some syndrome disease such as Marfan syndrome or Down syndrome, or other cardiomyopathy. But with the improvement of the ultrasound machine, the sensitivity of the ultrasound machine have improved a lot. So in some cases, we can see low or small regurgitation from tricuspid valve, and their ultrasound features we saw the low or small regurgitation from the mitral valve, and no other problems. The fetal developed well, and they are born, and some of them are born normal. So about these features, we saw the medium regurgitation from the mitral valve, and we didn't find another or other problems. And so we needed to follow up. We needed to accumulate more experience to improve our knowledge. So maybe we can't say it's exactly normal, but we can't say it's abnormal too. So we needed to follow up.
Okay, thank you. So because of the ultrasound machine developed, so the regurgitation of the mitral valve may be not complied with other congenital heart disease from phenomenon. So maybe it's just the baby, maybe is a health one. We need to follow up. So the couple do not need to so anxious with the fetus. Is that right?
Yes, yes.
Okay, thank you.
And I have a question to Sheng Zhao, doctor. You just talk about the prognosis of fistula. I want to know in what condition we need to have a surgery after birth, and what condition we need to follow up.
Okay, thank you for the question. It's a little bit difficult for me to answer this question because I mainly do fetal echo. So I think if there's no heart failure or coronary steal effect in the baby, maybe we can follow up and wait the close of the fistula. If there's still a very huge fistula and there's some sign of heart failure, maybe we should do surgery.
Yes, I agree with you. Because we thought in the past, we thought the fistula is a very severe disease. So once we diagnose it prenatally, the pregnant woman choose to terminate the pregnancy. But recently, with the improvement of our prenatal diagnosis, more and more people, more and more fetal heart disease was diagnosed prenatally. And some of the pregnant women choose to continue the pregnancy. So it's necessary, or it's what for our ultrasound doctor to know the prognosis of different disease, including heart disease or other disease. 2 years ago, we diagnosed a fistula, and with the primary atrium septal defect. I thought the baby should to be to get surgery immediately after birth, but when I follow up, she told me she was in the surgery doctor, heart surgery doctor told she to follow up. Don't hurry and don't worry. Maybe they will close ultimately. So I think maybe we need to add not pediatrics, but fetal what? 小谢。
Yes, very good.
建立fetal，我说中文吧，就是可能不只是我们说见到儿科，然后我想这儿科也是随后建立起来的。那么现在我们产前诊断发展到今天，那么有可能去建立一个就是胎儿科，这样子的话，才可能就是很好的去发展我们胎儿医学。
Maybe fetal surgery. We can build a fetal surgery department to diagnose and treat the patient with prenatal diagnosis of CHD.
Yes.
I agree with Professor Pei, but in fact, this kind of idea of multidisciplinary team, so-called MDT, is very popular in the West country as well as in China. In our university, I am in charge of the fetal medicine and the prenatal diagnosis department in our hospital. When we encounter this kind of fetal CHD, we call a meeting. We invite the pediatric cardiologist, cardiologist surgery, and pediatricians together. We discuss the outcome and the possible management of the fetal safety together. If we do this kind of MDT, the couples can listen and discuss with the ultrasound doctor, the fetal medicine specialist, as well as the pediatric doctor and the pediatric cardiologist. They can understand better how about the prognosis of this kind of cardiac abnormalities, how about the prognosis, how to deal with this disease, whether it's need to do surgery or do expectant management or do medical treatment, etc. So I think MDT is very important in the deal with congenital heart disease. Is another question left to Professor Li. Can Dr. Xue convey this message to Professor Li?
Okay. The question is how accurate is AI in doing the fetal biometry in your experience? Can it be applied to other parameters as CM and left ventricle measurements, AFI, etc.?
We only do the measurement for BPD, AC, HC, and FL. Only 4 basic parameters. For these basic parameters measurement, the result is very, very good. And compared with the professor and the SF, we are do the same. I think it's good as the professor's work. That's all. Thank you.
So in the future, do you have a plan to study to use AI to measure other parameters such as left ventricular measurement and AFI? I think it's easy for you because you have a very huge database and a very good research team.
Yes, and in the future we will have about 10 to 20 to 15 parameters to measure automatically, especially for the heart.
Thank you.
Thank you.
So any other questions? So how about the time limit of our session? Shall we close or we can continue? Okay. So how about Anise? Are you here? Shall we close or move to the next session?
Jeff, this
Break time now.
I think time is now. Okay. Okay, if no further questions, maybe we just stop this session. We appreciate all of the speakers' excellent lecture, and we are looking forward to your future research presentation in the near future. Thank you so much.
Thank you. Thank you, everybody.
thank you very much.
Thank you.
Have a good night. Bye bye.
Bye.
Bye bye.
Goodbye.
Bye.